Hello and welcome to the Abdominal Sonography logistic. So today we're going to go over the gastrointestinal tract and the abdominal wall. Now it's important to understand that sonography may not always be the modality of choice for detection of all GIT abnormalities, but it does provide an non-invasive, non-ionizing diagnostic instrument. We will go over the GIT structures and how we analyze them. So there are a few key terms, for example, acute appendicitis, inflammation of the appendix, bezoars, the masses of various ingested material that may cause an intestinal obstruction. The cinnamon bun sign is a sonographic sign associated with the appearance of intussusception. Crohn's disease, an autoimmune disease characterized by periods of inflammation in the GIT. The donut sign is a sonographic sign associated with pyloric stenosis. The McBurney point is a point halfway between the anterior superior iliac spine and the umbilicus. Meckel's diverticulum is a common congenital outpouching of the wall of the small intestine. Midgut malrotation is an abnormal rotation of the bowels, which leads to proximal small bowel obstruction. Non-bilious means not containing bile. So we come to the anatomy of the GIT. So we can refer to the GIT as the alimentary canal, and it consists of the mouth, the pharynx, the esophagus, the stomach, the small intestines, and the colon. The mouth is the most proximal portion of the GIT, and the pharynx lies distal to the mouth, and unless, unites the pharynx to the esophagus. The esophagus travels inferiorly within the thorax, and through the opening in the diaphragm, we call this the esophageal hiatus. The distal esophagus unites with the stomach. This area we know as the gastroesophageal junction can be identified, and it will appear as a bullseye structure between the left lobe of the liver and the abdominal aorta in the sagittal imaging plane. The stomach consists of the fundus, the body, and the pylorus, with the distal stomach lying upon the pyloric sphincter. And the pyloric sphincter is a muscle that controls the emptying of the contents of the stomach into the duodenum. The proximal duodenum is a C-shaped loop, and we refer to this as the C-loop of the duodenum. Distal to the duodenum are the jejunum and the ileum of the small intestines. The ileum meets the cecum, or the proximal colon, at the ileocecal valve within the right lower quadrant of the abdomen, and at this level there's a blind-ended tube. We know this as the vermiform appendix, and it is connected to the cecum. After the cecum, the colon is termed the ascending colon, and it travels superiorly towards the liver within the right side of the abdomen. A bend in the colon, we refer to this as the hepatic flexure, or the right colic flexure, marks the beginning of the transverse colon. And the transverse colon travels along the abdomen and bends at the region bordered by the spleen, and we call this a splenic flexure or the left colic flexure, and it is located inferior to the spleen. And this marks the beginning of the descending colon, which is located within the left side of the abdomen. The colon travels inferiorly and becomes the sigmoid colon and subsequently the rectum. And the egestion point here, known as the anus, is the external opening, and it marks the termination of the alimentary canal. Most GIT parts are considered intraperitoneal, with the exception of the duodenum and the ascending and descending colon, which are regarded to as retroperitoneal in location. Just zoom in here. The alimentary canal begins at the esophagus, and the esophagus eventually unites to the stomach, and the stomach drains into the duodenum, and the duodenum drains into the jejunum, then into the ileum, then this drains eventually into the cecum, into the large intestine, into the ascending colon, which then becomes the transverse colon, and then the descending colon, and then sigmoid colon. So how do we find the colon on sonography? So we have a normal gut signature, and it should be noted as 5 histologic layers that sonographically appear as alternating echogenic and hypoechoic segments. And these are the 5 layers: layer 1, 2, 3, 4, and 5. Although these are not always consistent, um, the alternating echogenities of the bowel layers should produce a target or bullseye appearance. The sonographic examination of the GIT should include graded compression or compression sonography to differentiate normal from anomalous bowel. Specifically, normal bowel should be compressible and should show observable peristalsis. So compression of the bowel will also move intraluminal fluid and or gas out of the area of interest. So generally, the normal intestinal wall should measure less than 5 millimeters in thickness, and a normal bowel wall segment produces little to no color Doppler. Consequently, color Doppler can be beneficial to examine inflammatory changes. So the layers of the gut include the superficial mucosa, which is the innermost layer, and it is quite echogenic. The deep mucosa is hypoechoic. The submucosa or the muscularis propria interface is echogenic. The muscularis propria is hypoechoic, and the serosa is echogenic. And you can see this right here, the echogenic superficial mucosal layer, which is number 1, then the superficial, the hypoechoic deep mucosal layer is number 2, then the echogenic submucosal layer is number 3, then the hypoechoic muscularis layer is number 4, and the echogenic serosa. Now we can look at acute appendicitis. So the appendix is a long, narrow, blind-ended tube, and it's commonly located within the right lower quadrant at the level of the cecum. Inflammation of the appendix has been cited as the most common cause of acute abdominal pain resulting in surgery. And acute appendicitis may be the result of some form of an obstructive process, such as an appendicolith, a fecalith, a lymph node, tumor, etc., or maybe even a parasite. So clinically, patients will present with initial epigastric or general abdominal pain, nausea and vomiting, high fever, and possible leukocytosis. Sonographically, we find a non-compressible blind-ended tube measuring more than 6 millimeters in diameter from outer wall to outer wall. The echogenic structure within the lumen might represent an appendicolith, and hyperemic flow within the wall of the inflamed appendix, as well as periappendiceal fluid collection. So in this image we have 1 a longitudinal and B transverse image of an inflamed appendix. Next, we can look at hypertrophic pyloric stenosis. And the pylorus is the distal region of the stomach. The pyloric channel is located at the distant portion of the pylorus between the stomach and the proximal duodenal bulb. And in this region, we have a group of muscles known as the pyloric sphincter, and these control emptying and prevent undigested food from reflecting back from the duodenum into the stomach. And hypertrophic pyloric stenosis present clinically as projectile vomiting, weight loss, constipation, and sonographically we see an abnormal pylorus as a target or donut in the short axis view, and it appears as a cervix in the long axis view. The wall of the pylorus will measure greater than or equal to 3 millimeters in thickness, and the length of the pyloric channel will measure greater than or equal to 70 millimeters. Pyloric stenosis defines less target appearance, known as sphincter muscle. Longitudinal image will reveal this sort of cervix-like appearance of an enlarged sphincter muscle. Interception. We have the most common type of interception is the ileochoric interception, and it occurs within the right lower quadrant at the level of the iliacal valve. So graded compression should be used to evaluate the patient with clinical findings. Interception will appear as a target mass in the transverse plane or as a pseudokidney in the longitudinal plane. It will have alternating names as echogenicity representing the edematous level of the bowel wall. Clinical findings include intermittent severe abdominal pain, vomiting, palpable abdominal masses, red currant jelly stools. On the sonography, we see an uncompressible target-shaped or pseudokidney-shaped mass that consists of alternating rings of echogenicity. I would refer to this as the Simon bun sign. The diameter of the intercepted bowel will exceed 3 centimeters. It's a transverse image representing the donut or some sort of target sign, or what you can see the cinnamon bun sign. Although sonography is not typically the diagnostic modality of choice for intestinal obstruction, a mechanical obstruction resulting from bowel can be viewed at sonography. And here we see a distended fluid-filled lips of bowel, and an abrupt termination point of the distended bowel may be identified. Increased peristaltic motion with to and fro intraflow of intraluminal contents. Crohn's disease is an autoimmune disorder characterized by periods of inflammation of the GIT. You will see bowel wall thickening, and the affected bowel will be non-compressible and have a target appearance. We will also see a hyperemic bowel wall. Diverticulus. Diverticulosis is the development of small outpouchings in the digestive tract. Most often this occurs in the sigmoid colon. Sonographically, we see a segmentally thickened bowel with evidence of an inflamed diverticula and an inflamed perimetric fat portion. The affected bowel segment will typically reveal hyperemia. An inflamed diverticula may appear as echogenic projections from the bowel that produce shadowing or a ring outline effect. Colitis is an inflammation of the colon. There's several different forms. There's pseudomembranous, ulcerative, ischemic, and infectious. Clinical findings include watery diarrhea, which could be bloody, could be abdominal pain or fever, and sonographically we see thickened hypoechoic colon walls, and we see hyperemia within the colon wall. Gastric cancers are the most uh, common malignant tumors of the bowel. The most common form we see is the adenocarcinoma, where patients typically present with weight loss, abdominal pain, anorexia, and vomiting. At sonography, we see a hypoechoic irregular-shaped bulky mass within the bowel. The rectus sheath hematoma. The rectus sheath forms a covering for the pancreas abdominis muscles, and the rectus abdominis muscles are found on both sides of the midline of the interior abdomen. They are divided by the linea alba, which is located in the midline of the abdomen. Rupture of vasculature can lead to a rectus sheath hematoma. Sonographically, we see blood that can be hypoechoic, complex, and anechoic depending on the stage of development. Endometriosis. The most common site of this after the femopelvic region is the abdominal wall. Endometriosis is ectopic functional endometrial tissue, and it's typically located within the scalp or previous cesarean section, and is thus termed scar endometriosis. We would see well-defined lobulated infiltrated masses that are hypoechoic to the adjacent blood tissue. Anterior abdominal wall pathology, in this case hernias. Often we employ the Valsalva technique to show movement and change in size of the hernia. Hernia should be carefully examined for bowel content and peristaltic motion of the trapped bowel. So inguinal hernias are located around the groin or the scrotum or the labia. The bowel protrudes into the groin, and they can be direct or indirect. Incisional hernias is a surgical incision site. This is where bowel protrudes into the surgical incision site. A linea alba hernia is where bowel protrudes through the fascia of the linea alba in the midline of the abdomen. We have umbilical hernias where the bowel protrudes into the umbilicus. We can have sympembrian hernias where bowel protrudes into a weakened area in the lower one-fourth of the rectus muscle.